I feel tremendously guilty because I watched during the last 20 minutes what was going on, and it looked just like Nicholas's slides, these networks right and left, and my guilt is we had to stop that networking, and we know how valuable they are from Nicholas's talk. So I know the agenda has been put together very, very well so that we have plenty of time for social networking after this, and I thank you very much for your attention during this time. I'm here to present a topic, scale up of evidence-based innovations in family health. And I'd like to acknowledge my co-author who is in the audience, Leslie Curry. As well as our collaborating team at Yale and of course our funding from the Bill and Melinda Gates Foundation. I have to say, when Wolfgang approached us about this topic, I could not have been more excited because we had spent so much time as academics creating what is evidence, we think, credible evidence about how to do, you name it, to improve health. And yet all of us had traveled, all of us had been through our real lives and knew these things aren't being taken up. And so our science began to try to understand what is it that allows things to be taken up or impedes that kind of evidence. So when something as large as the Gates Foundation said, this is something we're interested in, we were on cloud 9. So a little bit of background. As we know, many innovations are efficacious, cost-effective, but they fail to scale up. The question is, why is it, and what can be done? We have actually quite a bit of literature. Many of the people in the room have created a lot of the literature about this in the US and Europe. But there are several gaps in our understanding about this process globally. How does it happen globally? A few of the major gaps that I hope our research will help fill. First, we really lacked a comprehensive synthesis of the evidence and experience. If we went through this room and all the people you know and the people they know to 3 degrees of separation, you've been very involved in making change in individual settings, individual pilots, individual cases. But putting that together to understand what are the key themes in this, so maybe we can learn from all of our individual experience, that really hadn't happened before. In addition, we have important work on individual behavior change, but a lot less attention on achieving large-scale change. And particularly, we have a limited understanding of the distinct role of groups. Nicholas talked about social networks. I'll talk a fair amount about groups, that is, organizations and communities. These things we knew less about. And therefore, our objective, and what the Gates Foundation had asked us to do, was develop a practical model of scale-up in the area of family health innovations, which would be applicable in low-income countries. And we wanted to pay particular attention to the role of groups in this scale-up process. Now, the Gates Foundation also had several ideas about the kinds of projects or the kinds of innovations they wanted to know more information about. And so we were asked to look at successful scale-up in 3 particular areas: products, practices, and platforms, which will also be the framework that's used in the afternoon. In the area of products, the example was Depo-Provera, the long-acting injectable contraceptive, which is effective, easy to use, but really very underused right now in low-income settings. The area in practices was exclusive breastfeeding. We heard a fair amount about that from Melinda this morning. Substantial nutritional and immunologic benefits for children, et cetera. And our example in the platforms was the community health worker approach, the integration of community health workers in health systems. And this has been linked already as an actual innovation to reduce neonatal mortality, reduce child mortality, better prenatal care, more cost-effective care. We know these 3, pretty much know, there's always the slight question, right? We know these 3 innovations have tremendously successful outcomes when used, and yet we also know they're really not scaled. So these were really the lenses that we chose to look at the issue of evidence-based scale-up. Let me spend 1 minute on our research methods. So I think this is very important, what we were able to put together. First, we did a systematic review of the peer-reviewed literature and the gray literature. This included 11 electronic databases of searching, key documents from 20 global health organizations for the gray literature. And yes, it did produce almost 1,500 articles, which, yes, we did read. Of those 1,500, only about 75 are really empirical stories about scale-up that give us key information about what are the best practices in scale-up. But it really wasn't enough to look at the peer-reviewed literature because obviously people don't publish all the great things that happen. We have the wisdom of communities themselves. So we also conducted 27 in-depth interviews with experienced practitioners, some are in the room today, and policymakers. And we use state-of-the-art qualitative methods to extract what were the key understanding and the key themes. I would also just add that we spent an enormous amount of time studying the theoretical background to scale up so that we would be sure we didn't miss an entire discipline. This ranged from economics, sociology, biology, you name it. We tried to study what people had put forth in scale up. Today, and as I understand it, these couple of days are to really describe what we've come up with relative to this literature and this wisdom from interviews in its model, and spend the time pressure testing it, get questions, refine it, change it, make it better, adapt it, et cetera. So we're very open and excited about the conversation to take place now. So I'm going to show you a picture. This is the AIDED model. This is the acronym that we are using to describe the model of scale up. And it has 5 components to it: assess, innovate, develop, engage, and devolve. And I'll spend the next few minutes talking about each of these with some examples. But before I get there are a couple things about this model that are important. First, it's nonlinear. Everybody wants to say, just tell me, step A, B, C, D, E, I do that and it's done. That is just not what the literature says. It's not what experts say. Much more than something linear, checklist like that. What we really found is what has been, and many of you know, really known as a complex adaptive system. That means it has interdependent parts. How the second part works actually depends on the first part, and vice versa. It has multiple feedback loops, therefore the spaghetti strings there. And the most important thing probably from the literature is there's no single path. So we just have to be careful not to make that same mistake that is often made in science from the very beginning, that, well, just give me the pill and that's how it'll work. This actually, our literature describes that there really isn't a single path. There are multiple paths to potential scale up. The model really refutes the myth of the magic bullet. Really suggests instead there is no one single way. There are multiple ways. Some of these may be predictable, others less so predictable. I also just want to tarry for a moment on what distinguishes this work from the work before, because there were mountains and mountains of frameworks about this. And there are a couple of things. The first is our work really focuses on the mechanisms, the way, not just what are the pieces, but how the pieces fit together. And we think this is particularly important because if one is going to replicate it all, sort of understanding how these things might logically fit together is as critical as just describing what the actual components are. Okay, so I'm just about to go into the 5 components. So where do we begin? We begin with assessment, and I have to tell you, the experience of doing this project over the last year was fabulous, except we kept starting with the innovation because people said, tell us how to spread depot, tell us how to spread breastfeeding. So we started with the innovation, and we just, much as we tried, that is the wrong place to start. The right place to start is assessment. And assess what? The symbol here is of a user group. We mean by that, for instance, the village in Africa. Again, I'm interested in groups and communities. The entire village in Africa that you might want to start exclusive breastfeeding in. For instance, the village in Bihar, India. And what do we see about this, assessing this village, assessing this user group? You see a carve out of the circle. That's a need. That is a symbol for there's some receptivity in that group. There's some demand potentially. There's something that if they had it, they would be whole. And this is pretty straightforward to assess needs in other fields. Public health, we do that all the time, needs assessment. Marketing, business, market assessment, want to see if we can sell our product, et cetera. It's very, very straightforward, except if you're thinking of this with an eye to scale up, and particularly scale up of family health interventions, then immediately this assessment piece becomes much more complex. Complex because you might want to assess what kind of network are they in. Is this real? You might want to ask some of those questions. Complex because when we really look at a whole set of user groups, they vary. They vary in their receptivity, they vary in their needs. And we have one quote from one of our interviewees that I think really describes the conflation and the confusion between need and demand in public health. He says, in public health, there's often a lot of confusion between the need and the demand for innovations. There's a tendency to approach the idea with, okay, I look at the incidence of disease, I know the particular intervention that can solve the disease, why isn't this diffusing? And the answer would be on this slide, that the user groups may actually all have the same need, but may be totally different in their receptivity to what one has to offer. So that's something we can really learn from economics about understanding, well, are they receptive? Therefore, would this ever translate into demand? The second reason assessment becomes very complex from the very beginning is that user groups exist within a context. And the context would include the economic, the political, the regulatory, perhaps the network or sociocultural environment. And because family health is such a social behavior, set of social behaviors, understanding this context is critical for promoting or impeding scale up. And this, of course, is something that we learn from anthropology, sociology, and social psychology. In this model, the point is that the assessment would need to be intensively on the user group and intensively on the environment in which they live. In the case of community health workers, for instance, we find situations where the economic environment is such that there's a competitor to the community health worker. Somebody does not want the community health worker there because it will take away their particular market that they may be, providers may be making income on. Or the political environment. Is the Ministry of Health really wanting community health workers or not? Or the social cultural environment. Are there traditional birth attendants who actually are the trusted people? So a community health worker on top of that isn't necessarily going to be trusted. Those are the pieces of assess that are critical. In ending the component of assessment, I would just say that there is good evidence that without the proper assessment, the scale up ultimately will fail. So moving on to Innovate, the second component. There are two key pieces of Innovate. Two key points. First, this is a completely dynamic process. We can't take it off the shelf and know this is the innovation. And second, fit of the innovation to the user group. It is absolutely essential. So I want to take an example. And I hope Mary Taylor will allow me to embellish a little more than just the exact facts of it. But I think it's very good for the illustration. In Nepal, a fabulous community health worker program existing for decades now. But how did this begin? Was it one sort of an off-the-shelf set of someone at WHO and others have a generic, here's the box, here's how you do it. Here is community health worker, 1, 2, 3, 4, 5, these are the things you have to do. I think so. But how does something like that shift over time? And in this case, shift thinking, what does the environment really want? Do people really want vitamin A? Is that one of the most important things? Is pneumonia care something that's credible among our Nepalese women in adopting the community health workers' work? So you could see a shift could happen. And one of our key informants described this. In Nepal, the fit manifests in the tasks given to community health workers. The community health workers ultimately provided vitamin A, which very visibly made children healthier and reduced mortality. If the community health worker missed a visit, families would call them and say, hey, where's my vitamin A? Whereas we know that is not a typical situation where that kind of demand, because the innovation is designed so perfectly, exists. So the idea in innovation is that it has to fit exactly what that receptivity is, again underlying why assessment is critical from the beginning. The third component is develop. Develop is priming the environment. Develop is addressing the resistance. Develop is building support in the environment that will help make it conducive to spread this kind of innovation that one has. And we symbolize this by the greening of the environment here, making it more conducive to what would possibly be taking on the innovation. Again, in the community health worker example in Pakistan, their effort, one of the key informants described, well, we spent a year collecting and generating local data on perinatal mortality, its distribution, its causes. This, more than anything, was critical in focusing attention of the local politicians, and we made several presentations to the Minister of Health and Director General. This is what persuaded them to do something. That only gives a very small piece of the developing the environmental support that was used in Pakistan before the spread of community health workers to really ultimately know that there would be economic and political support for the innovation. I'd like to move from here into the fourth step, which is engage. But before I do, I think most of us in the room might think to ourselves, well, if I have a great innovation that I know fits, and I've primed the environment perfectly, the minister is happy, you know, we have an economic model that works, I've got scale up, down, pat. I got a good innovation, I got a good environment, how could I go wrong? And so the fourth step is where we could go wrong, which is engagement. How do we actually do the engagement? Now, it comes fourth because you've got to start somewhere, but this is right in the beginning of assessment, the engagement from the get-go. It's fourth because it also is critical at this point as well. So what are the pieces of engagement? And this, I think, is a part of the science that really has not been, probably from practitioners' point of view, has been used frequently, but is less documented in the peer-reviewed literature, although I think that we can really start to see where we've been successful this has happened. We often think, what is the first piece? Well, we got to tell people about the innovation. We have to bring the innovation to the group that's going to take it up, the first set of user groups. That would be introduction. And you can see already with the puzzle piece, it fits, it's introduced. And many times we might say, well, that's enough. And I think with social networks, you might say, give it to a super spreader. They're connected to everybody and off it'll go. Our evidence suggests there's something a lot more complicated within that village, that group, perhaps that network that goes on. The second piece is translation, and you can see we've turned the puzzle piece, which is the symbol of the innovation, from black to more of the brown color that fits better with the community. And this piece of translation means converting whatever it was to something the community understood. And when Melinda described the issue of how they figured out the umbilical cord would dry better without oil by saying, what about bread if you put it out in the sun? That was translation. That was taking what all the science says and says, well, this is something everybody will understand. We'll put it in terms of bread. And in fact, we saw this as well. One of the quotes about, again, I tried to stick with community health workers. Our best community health workers were the cleaning ladies because they knew how to talk with the women. They knew the vocabulary. They were the same neighborhoods. They were more or less the same age. They talked to them very easily and could persuade them to breastfeed, to use contraceptives, whatever. Again, a translation. Second, or I guess third piece here is the integration. This is moving from, okay, I understand it. Now it's been translated to words our group uses. And now how do we integrate it into the social norms of that group? And in Nepal, again, an example from community health workers, the idea that doing community health work could potentially get you dharma, could get you some kind of religious merit. Now, we may feel good or bad about that fact that that's how that was used. Nonetheless, it was quite effective and had women being much more sort of in the social norms of doing community health work. And then last, the replication and adaptation within that first user group still. This is not devolved out to other user groups, but within the first generation of user groups. We asked our key informant, well, how did that spread within one community? How did more and more women want to take on community health workers? And the key informant said, well, there was an advertisement campaign to get community health workers, but much more than that. It was peer pressure, a sisterhood. Women stayed as community workers for their whole career, and they ended up passing it down to their daughters. Now that's sustainability. So this is the idea that within that first generation of user groups, you would be able to saturate in a very effective way the innovation and the use of it. So let me turn to the last phase of this, which is devolve. And this is when the first user group is able to then send this innovation, if you will, have it replicate outside the first piece of the, outside that first set of user groups. And we see in the literature three different paths. One, it replicates. It's exactly the same thing coming out. It hits a user group that's exactly the same receptivity, and the thing is adopted. Two, it's adapted when it comes out. It's a little more bulbous there, and it's not exactly the same, but If that hits a user group that is identically fit for that, then there will be adoption as well. And last, we see this frequently, the graveyard of pilots, I think Gary described, where there's failure. It comes out the same way, but it hits a user group that is absolutely not receptive. And this idea is that that third set of user groups are probably in a different environment, maybe a different social environment, social network. They're not in the exact place as the others. And as we heard people talk about this process of diffusion, or devolution as we've called it, they would say, well, this is not a predictable process. The diffusion is not something a funder or grantee, not even the ministry, can really handle. They're on social systems. They're already operating. I mean, the relations between neighbors, households, these serve the purpose much more. These serve other purposes than healthcare delivery, but this is what spreads the innovation. I want to take one step back to say, nice model, let's see if it really works with the literature we have. And this is a summary, which I won't go into tremendous detail, but of the 23 papers that describe and give us empirical evidence about scale-up in community health workers. And we tried to characterize the barriers to scale-up and the enablers to scale-up. And just to take a look at the barriers, we mapped these directly to the 5 components. And insufficient pay or insufficient non-monetary incentive for community health workers was the #1 reason for failed scale-up. And this fits, we think, directly in the innovation. Is the thing designed correctly? Weak management and supervision of the community health workers is also a very strong reason for failure. Again, likely in something like the actual shape of the innovation. The lack of community support and perceived value, we heard in the Nepal example, that was not a problem, but that is a very strong problem we see in many of these experiments. And this we'd really say is a failure of assessment, so you're really not sure what kind of support you have, and a failure of engagement. How do you actually drive the support? And last, the community health workers not being integrated into the hierarchy of the health system itself. So having champions in the health system itself, this would be a failure of develop. We painstakingly went through all the literature this way, and I can pretty safely say that all of the barriers and the enabling factors would fit in one of these 5 components. So it seemed as if it was a good fit to the empirical evidence we have. Let me just, I think my time is about up. Let me just end with sort of repeating where the aided model is and a couple of sort of key take-home messages about this. I think the first one is starting with the communities, and starting with communities and environments that are receptive is #1. And we say this a lot, but I can't tell you how many examples there were where that did not happen. We think we're doing it, but are we really doing it? Starting with the community, not the innovation. Start with what their receptivity is first. The second sort of key take-home is ensure the fit. We get pretty wed to the innovations as a scientist. I get pretty wed. I know what the evidence said worked. I wanted that done. But that just is antithetical to scale up. What is consistent with scale up is forcing the fit, forcing the innovation to shift to fit what the community is receptive to. Third, developing support at all levels is essential. Fourth, and this is maybe I think one of the more important pieces of this, is failure to scale up is largely a failure to engage properly with that first generation. If they're going to be the pushers, if that doesn't get into the social norms, the fail-up will scale. And then last, as I started with, we really have to say there's no single magic bullet. The collaboration across professional groups, sectors, communities, that's going to be the key. So you can see why this would be such a fascinating moment for us to be able to be in the community of scholars and practitioners and policymakers who are here, because probably among all of us we can figure out much better ways to use our resources to scale up. Thank you.